you guys are expecting a quarterback who's left-handed from the San Francisco 49ers, but I did grow up in San Francisco, so I am a big Steve Young fan. Not of myself, but a football player. A couple of disclaimers, since we're being filmed. I just want to make sure that you all know that this talk is not to replace a doctor visit, or a visit with a surgeon, or a visit with an oncologist. Okay, these are generalizations that we are giving. And when you do see a doctor, they're going to individualize your treatment. Okay, so these are all generalizations that we're talking about today. So I was asked to talk about the surgical treatment in melanoma. And there's really two take-home points here that I want to get across. Actually, one. The goal of surgery is for local regional control of the disease. Local regional control. That's the name, that's the word of the day, okay? And basically what we need to do is excise the primary tumor. And number two is determine whether we need to do a lymph node biopsy. And if there is a lymph node that is positive, then we need to get regional control by taking out the rest of the lymph nodes in that area. Okay, local regional control. So when we talk about surgical treatment of melanoma, the one thing that we do have is a guide in terms of how much surgery do you need. And the way we determine that is actually through staging. For every cancer that there is, there's a staging process. Okay. Staging involves, number one, there's three components to staging. Number one is the tumor thickness. Number two is the nodal status. And number three is if there's metastases. Everyone got that? Number one. What's number one? Thickness. Number two? And number three, metastases. Very good. What's the word of the day? Local regional control. And use your subs again. So when we look at staging for melanoma, I'm going to focus mainly on thickness. Okay. So thickness is divided into everything that's in situ, means it's not invasive melanoma, meaning it hasn't crossed what we call the basement membrane. When we start looking at invasive melanoma, then we start looking at things that have crossed the basement membrane, and we're breaking up into less than 1 millimeter, 1 to 2 millimeters, 2 to 4 millimeters, and then greater than 4 millimeters. Now, just to get a conceptual idea of what that means, if you look at a pencil tip, that's around 1 millimeter. If we're talking about 2 millimeters, that's around a tip of a crayon. And if we're thinking about 5 millimeters, then we're thinking about the width of a pencil. I did measure this last night just to make sure, and the pencil eraser is around 5 millimeters wide. So number one, in situ melanoma, that's an example of in situ, it hasn't crossed the basement membrane. As we go down further, the T1 lesion goes down 1 millimeter depth. As we progress, a T2 lesion goes 1 to 2 millimeters. A T3 lesion goes even further, goes to 2 to 4 millimeters. And a T4 lesion goes greater than 4 millimeters. Okay? So, my goal is to excise that whole tumor that you're seeing right there. Okay? And the way we excise it all the way down to that yellow tissue down at the base that you see there. Even through the yellow tissue, that's the subcutaneous fat. We excise all the way down to what we call the fascia. That's the outer layer of the muscle. Okay. So what's my goal with surgical margins? Okay, you may hear this term. These are the current recommendations by the NCCN, or National Comprehensive Cancer Network. And basically for an in situ lesion, meaning a non-invasive melanoma that hasn't crossed the basal layer, it's 0.5 centimeters. Sorry, I forgot centimeters up there. So what's the margin? So when you look at that lesion in the center, imagine we draw a circle around that lesion. That circle has to have at least 0.5 centimeters around it, all the way around, okay? And from a surgical standpoint, the way we do it is we make what we call an ellipse. You see that outer line that looks like an eye? That allows me to close that excision in a straight line. Okay, so your final scar is a straight line. So we're also looking at this margin. Okay, when it's a T1 lesion, my goal is to have a 1 centimeter margin. 1 to 2 millimeter depth, then our goal is 1 to 2 centimeters. The max really is 2 centimeters in terms of margins. Anything greater than that, they have not shown any benefit. There was several studies comparing 2 centimeter margins with 4 centimeter margins. Really, 2 centimeters is adequate. Again, these are generalizations. There are some exceptions, such as on the face, such as on the fingers or toes. So there are exceptions to these rules. Okay? And again, that has to be individualized. When we start looking at the T2 through T4 lesions, first of all, I'm going to say T2 and T3 lesions, that's from 1 millimeter to 4 millimeters. That's what we call intermediate depth. Okay? Anything less than 1 millimeter is actually called a thin melanoma. Anything greater than 4 millimeters, that's actually a deep melanoma. So for those intermediate deep melanomas or the deep melanomas, there is increased risk of lymph node involvement. Okay? There are a couple other components to staging, which I am not going to go over today, that make it a little more tricky because you probably won't remember it. But number one is if you have ulceration, okay, that actually bumps you up to a 1B. So there's certain components that actually increase the risk of lymph node involvement. One is ulceration, okay? The second thing is something called mitotic figures. That's from a microscopic standpoint. When they look at the actual specimen, they can actually determine how fast those cells are dividing. You guys remember mitosis? So if there are mitotic figures, that also increases your risk of lymph node involvement. There are a couple of other risk factors which I haven't put up there. The depth of the layers of the skin that has gone into. The other things are like lymphovascular invasion, things of the sort. That increases your risk of lymph node involvement. So if there's that increased risk, our recommendations from a surgeon standpoint is actually to determine if the melanoma has spread to your lymph nodes. Okay? And back in the day, before what we call sentinel lymph node biopsy, people used to have radical lymphadenectomies or radical lymph node dissections of the armpits or the groin to determine if there is spread of the melanoma. Now we have a tool called sentinel lymph node biopsy, where we can determine where that very first lymph node that the melanoma drains to. Okay, and so that's at our disposal now, and it's made surgery a lot less invasive. So we can do this through a 2 centimeter incision rather than a 5 centimeter incision. So when you start seeing lymph node involvement, that brings your stage up to a stage 3. Okay, meaning it's a little bit more advanced melanoma. So my goal with surgery in this scenario is number one, well, what's my goal? Local regional control. So number one is to excise that primary tumor, and number two is to determine if the lymph nodes are involved. Okay, and the way we do that is through sentinel lymph node biopsy. Here's a little video. This is actually a video from on breast, but this gives you an idea. This is what a surgeon does. We inject some blue dye around the tumor. The blue dye will be taken up by the lymphatics, which drain the tumor area. And we look at that very first lymph node that you see there. And sometimes there's more than one. Sometimes there's 2 or 3. Okay. Before we do that, the radiologist do us a way to localize these lymph nodes for us is using a nuclear radioactive isotope. And basically what they can do is map out where exactly this tumor will drain to. Okay? Now I want to make sure you guys know, sentinel lymph node biopsy, with this, just the mapping does not tell us if that lymph node is positive or negative. It purely tells us where the first area that melanoma will drain to. Okay? You guys understand central lymph node biopsy?
Stage 4 melanoma is when the melanoma has spread to other organs. Okay? It can spread to the brain, it can spread to the lungs, it can spread to the liver. We've seen it spread to the bowel. Last week I took out a spleen because it spread to the spleen. So there's many different areas that this can spread. Okay, as Dr. Baughman recommended earlier, make sure you get your eye exams. Make sure it hasn't spread to the eyes. Okay, so that's melanoma in a nutshell. Again, these are all generalizations. Your treatment should really be individualized. And I want to thank you.